Good morning and welcome, everyone. Thanks for joining us for another episode of House Calls Real Docs Real Talk. I'm Chelsea Helms, coming to you live from the KNWA News Studio here in Fayetteville, Arkansas. And I just want to say, there it is. We have some drilling going on above us. The building is under construction, so bear with us as that goes on throughout today's show, because this is really an important topic for today. I'm so happy to be joined by so many of you to be discussing what I think is going to be a big helpful discussion this morning. Now, for those of you who don't know, House Calls, it's a great opportunity to ask questions, come together and ask these questions of health experts and walk away with the immediate answers that we all so want. All right, today we are discussing how racism and health disparities can affect a person's health. Like I said, a very big topic today. I think everyone will agree that we all deserve the opportunity to enjoy a longer, healthier life, but unfortunately, that's not the reality, and it doesn't happen equitably. Some communities face health disparities simply because of where they live, learn, work, play, and even worship. This, as you know, it's a tough topic, but it's one that's very important, and we know you have a lot of tough questions for us. So if you do have a question you'd like us to address today or maybe in the future, visit us at heart.org/housecalls. Submit your question, and you can even drop it in the comments below throughout the show. We'd love if you did that, and we're going to do our best to grab those and get the answers right away, and we're going to get to as many as we can. Now, if you've been with us before, you already know this, and you've heard me say a big part of this show is really your involvement, and we so appreciate that so many of you have been involved. I mean, I was looking at the Facebook comments and the LinkedIn comments before we even went live, and so many of you were already chiming in, so we appreciate that. So today I do have two things to ask of you guys. First, throughout the show, we're going to break for a few questions, and we hope you're going to respond using our easy text to answer feature. All you have to do is text AHA live to 22333. You can see it there on your screen. Now, we're not going to ask you for your name or any personal information, anything like that. It is simply a fun and easy way for you to answer. Now, after you do that, we want you to hit that share button, start a watch party, whatever's easiest for you. Let's just get more people involved in such an important discussion today. Now, like I said, it looks like we already have a great audience. I'm monitoring our Facebook Live and our LinkedIn, and you guys are joining in, and we are so excited. So let's go ahead and get started. With me this morning is Dr. Eldrin F. Lewis, Chief of Cardiovascular Medicine at Stanford University. Dr. Lewis, welcome.
Thank you very much, Chelsea. I'm really excited to work with you today and to have a chance to talk with you about racism and how it affects healthcare.
Well, we are super excited to have you, and I know that a lot of people at home are looking forward to hearing from you. So on the topic of access to healthcare, let's start with our first viewer response question. How often do you see your healthcare provider? So while we go ahead and look at the responses there, I want to hear from you, Dr. Lewis. What is your recommendation for how often we should see ours?
I think a lot of it depends on your underlying medical issues. Okay. For someone who's completely healthy and they're actually trying to prevent heart disease or prevent progressive disease, it's best to see your doctor once a year. But if you have other conditions such as heart failure, coronary artery disease, you've had strokes, then you will have to kind of follow the guidance of your doctors. But I would say that could be up to two to four times a year. The most important thing is if you notice that there's a change in your symptom, you should reach out to your doctor even if you don't have a scheduled visit.
Okay, that is good to know. So let's take a look at our options. So we had the once a year for the annual checkups, like you were just talking about. Another option, I have many specialists and I see them as needed. C, I try to stay away from doctors. Or D, I am unable to afford preventative medical care. Looks like we have a pretty good mix on the board there. The only one I'm seeing no one answer for is I try to stay away from my doctor. So that is good news. But I am surprised to see, and I'll have you weigh in on this, that so many people are unable to afford their preventative medical care.
I agree. And this is a state-by-state issue. But in general, because of the Affordable Care Act that was passed under the Obama administration, preventive care, at least that annual visit, should be covered regardless of your health care. A lot of times people really don't know, and it's cumbersome to try to kind of sign up. But the most important thing is seek the care, seek options, and it's worth the investment to try to find out how you can see a doctor at least once a year.
Well, and I think too, there are resources available out there that sometimes people don't even know are available to them. So maybe a little extra research can help with that. All right, let's go ahead and get started with our first segment, Health in the Headlines. So this week's entry is from Healthline, and it's titled, Racism is a Health Crisis. Why aren't we treating it like one? Dr. Lewis, do you consider racism a health crisis?
I do. I do think that racism is a health crisis. I think one of the reasons we don't treat it like that is because when we think of racism, we think of a lot of the social injustices, the things that we've seen prominently on TV. People don't really think about how racism affects their own health, but there are many different ways that can happen. I think the first way is just stress, and this is something that's hard to measure. You know, we know that acute stress can actually cause significant heart problems, increase the risk of stroke, cause hypertension. And we see this. There's something called the broken heart syndrome when someone has a traumatic event happen to them, or they've lost someone who was very close to them, especially if it was in a sudden way. And then they develop this dilated kind of heart, and they develop heart failure. We know that's called Takotsubo cardiomyopathy, or the lay term is broken heart syndrome. What we don't know is the impact of chronic stress. And we know that people who are facing racism on a daily basis can have chronic stress, and that can actually cause increases in activation of your kind of fight-flight syndrome, or the adrenaline or catecholamines, and that can actually lead to high blood pressure, stroke, and other issues. I think the other issue is lack of access to just housing and food. You know, if you have a copay of $15 and you're struggling to pay your rent, or struggling to buy food, it's kind of hard. That $15 can be insurmountable. And so people will stay away from the doctor sometimes because of the copay. And I would say reach out to your doctors, because there are many times when they can work with you with the copay, but you should not stay away from healthcare because of that. I think the third issue is trust. You know, if people have experienced racism, they may have mistrust not only among a group of people, but they could also have mistrust of their doctors. And that can be because of a variety of reasons, including some of the history of research in this country. But it also could impact not only the willingness of people to go and see doctors, but their likelihood of actually following the recommendations. It's amazing how many times I hear people say, well, I don't necessarily trust, you know, what the medical establishment is saying. I think I'm going to look to other sources. And this is a major problem. And then the last thing, which is probably the most difficult one, is if there is structural racism or inequities in healthcare delivery. And I think when we have this, it becomes a major problem. There are situations where patients may not feel comfortable going into the hospital because they feel that their care is different than other patients just because of the color of their skin. And whether this is real or a perception, the impact is exactly the same, that people are unlikely to go and get access. I think we need to work harder to do this. And I would actually say that in the midst of COVID-19, where we've now increased over 5 million people who've developed COVID-19 or SARS-CoV-2 infection, I would say racism is kind of like a virus. A virus needs a host to replicate. So that's why there's social distancing for COVID-19. And if you don't have a host for racism, it can't dissipate. It can't migrate from one person to another. And I actually think the antidote for racism is like an antibody, and that antibody is kindness. If we basically treat everyone the same and everyone like we want to be treated, it actually would go a long way for reducing racism. And I think that will translate into better health.
Wow, I love everything you just said, Dr. Lewis. That was incredible. The analogy there was also really well received, so we appreciate that. Look, we want to keep hearing from you, so we're going to go right ahead and move on to our next segment, You Ask, We Answer. And In You Ask, We Answer, we focus on your burning questions each week. We ask you to submit your questions, and we like to answer them here live. So if you'd like to watch some of our past episodes, you can do so. All you have to do, visit House Calls website at heart.org/housecalls, and you can find all of the previous episodes in one place. As you know, this week we are looking at racism's effect on health. So our first question for Dr. Lewis, it comes from Anthony in Baltimore. He asks, can we talk about racial bias in medicine and healthcare delivery? Is it connected to a lack of trust in the medical community by African Americans?
It is. First, I think there is racial bias. There are structural inequities. It's one of those things that it's going to be hard to measure. So, for instance, if someone comes in with chest pain in the midst of an acute heart attack, if you are a woman, sometimes physicians may say, oh, this is anxiety, here's an anxiolytic. That's a bias. If you're African American, they say, well, have you used cocaine? Is that the first question that you would get? And the question is that the first question that a doctor will ask when someone comes in the midst of an acute heart attack with chest pain? The problem is that's judgmental. And if that's the first question, they may shut down. Patients may shut down and may not actually not only interact with you, but also give you the detailed history that you need in order to make a decision and actually try to come up with a better strategy for managing the acute event. The issue with bias as well is it absolutely impacts access to care. And it's not only the fact that some patients may not get treated in certain areas, but the other issue is patients may not feel comfortable being treated. I remember when I was in Boston for about 25 years, I was surprised that my hospital was in the middle of a predominantly African American community, but yet they would choose to go to a hospital that was predominantly previously called the Boston City Hospital. And a lot of it was because there was a bias. In general, you received your health care at the city hospital. And you see this repeated across the country. So even when people have private insurance or we accepted all insurances, patients felt that they weren't welcome. And that's something that we as doctors have to do. We have to create a welcoming environment and make sure that patients feel comfortable at their most vulnerable time.
Yeah, absolutely. Because like we've talked about already, it's tough to make that decision to even get in the door, let alone to have to make that personal conversation with a doctor. So you're absolutely right. All right, Tanya from Chicago, she wants to know, what are some of the implications of underrepresentation of certain communities in healthcare and research?
Yes, this has been a very sensitive topic because it really boils down to, do you need to have congruence, or do you need to have similar providers providing care for their patients, and does it actually impact care? And they've done some research in this area, and in general, the research has been mixed. However, there are some benefits to having congruence between the provider and the patient. The first thing is relatability. When I sit down and talk to my African American patients, I can share some of my experiences when I was a child growing up in Mississippi. And I could actually use that to actually help change behavior. So for instance, hypertension is prevalent in the African American community. We know that salt intake is one of the risk factors for hypertension, and controlling your salt intake can go a long way. So when I sit down and I talk with my patients about strategies to reduce their hypertension in addition to antihypertensive agents, the first thing I have to do is to talk about the importance of hypertension. And so I do that, and I kind of use my own family experiences to help relate to my patients. And then secondly, I'll talk about traditional foods that I ate when I was a child and how we have to look at low salt options. And there are ways of fixing these foods without using salt, and even refer them to cookbooks. So by having that relationship and that kind of common background, it actually can be effective in counseling. The other reason I think it's important is that you never know what motivates a particular person. And sometimes a woman seeing a female doctor, an African-American or Latinx patient seeing someone from their culture will allow them to relax and then also share things that they may not share with other providers. So I think we have to kind of increase the pipeline. And the problem with this is we can't start increasing the pipeline in medical school. This starts in high school. So I want people to see me and say, I can be just like him, and then work to try to achieve that. And by having a large cadre of providers, not only will it allow us to provide culturally sensitive care, but it also will allow us to reach areas that have actually been somewhat inaccessible in the past. Rural areas, inner city. These areas are often where a lot of our underrepresented minority providers go to practice.
Yeah, really, really valuable points there. This next one coming to us from Renee in Nevada. She says, many studies have shown African-American churches can play an important role in providing health care, and churches have been successful partners in the fight against high blood pressure, which, as you know, affects more than half of African-American adults. So what's your perspective here, especially given what we've seen as a result of the current health crisis?
Yes, I think churches play a vital role. There's something called community participatory research. And I think this concept was novel at first, and now I think is vital. The reason is because of the lack of trust that we often have in the community. By having the church, it's a common place that a lot of people go. And what we can do is we can train people in the community to help us answer questions. It actually helps so that people don't have to necessarily drive for a distance in order to enroll in studies. And it allows us to answer some simple questions and really have pragmatic, simple solutions. You know, it reminds me of when I was getting my master's of public health at Harvard School of Public Health. I went back home to Mississippi, visited family, and I was telling my uncle, he asked me what I was doing. I said, well, I'm getting an MPH. And he said, why? And I said, well, I want to prevent heart disease, because heart disease is so prevalent. And he said, you don't need a fancy degree from Harvard for that. Tell people to stop eating fried chicken, and it seems like a simple solution. It was a simple answer. I probably couldn't do a thesis on that, but those simple solutions can actually have very impactful results. And so in the community, not only can we devise simple strategies for controlling hypertension or for screening for high blood pressure or screening for diabetes, things that are common in the community, but also we can think about how to do an implementation project. The one example that I'm sure a lot of you have heard about is the barbershop and the beauty salon project. There are many people who walk around undiagnosed with hypertension for years. That's why it's called the silent killer. It doesn't cause symptoms until you've had a stroke, until you've had chronic kidney disease and you're on dialysis, or you've had a heart attack or heart failure. And in those cases, then all of a sudden you say, wow, your blood pressure is 200 over 100. Well, the reality is a lot of people don't go for prevention, just like the first question asked, and the poll asked. A lot of people don't go because of the copay, because of the cost, because of access to care. So going to the barbershop or the beauty salon to measure blood pressure is a way of screening for hypertension and then actually implementing treatment. And this actually worked to control blood pressure more effectively than the usual care.
Very interesting. I had never heard of that. So thanks for sharing it. All right, we have a lot more to cover, but let's take a quick break for another poll question so we can hear from all of you again. So you know what to do. Grab your cell phone and get ready to text in your answer. As a reminder, all you have to do is text AHA Live to 22333. If you've already registered, you don't have to do it again. You just need to get ready and send in your answer, like I said, to 22333. We do want you to know, do you believe race plays a role in the quality of healthcare that a person receives. So let's go ahead and take a look at the poll questions. And while we do so, I want to give a quick shout out to some of our friends who are watching. We have Frank from Tampa joining us on our LinkedIn stream. We have Christina from Romania, and we have Lily from Brooklyn. So thank you all for joining us today. So excited to have so many people from around the country and around the world with us. So the answers are yes or no. Do you believe race plays a role in the quality of healthcare that a person receives? And, you know, Dr. Lewis, I know we've talked about this extensively, but I'll just open it up to you to comment if you'd like.
Absolutely. You know, my gut reaction would be, I want the answer to be no.
Sure.
And we need to get to a point where the answer is no. But unfortunately, because of what I've seen over the last 25 years, I would say the answer is yes. And it's not everywhere, and it's not to the same degree, you know, but even if it's a small impact on the quality of healthcare, that's a problem. The real issue is it's challenging to kind of measure it. You know, you would have to do an incredible social experiment where you would have actors go into the emergency room with exactly the same script and see if they receive different care. And that's difficult when you already have a burgeoning, you know, you have an emergency department system that's already overwhelmed. So it's hard to actually do the studies, but we do need to look at this. And the other thing that's really frustrating is the fact that our zip code is more important than our genetic code. As you mentioned earlier in the introduction, that where you live actually has a major impact in how long you live.
I love the way you put that, your zip code. That's a really great way to associate things, and I think it's a great example. All right, before we jump back into your questions, I want to take a moment to tell you about a really timely initiative. As you might remember, we talked about this last week, but given the topic today, we thought we would mention it again. It's the Empowered to Serve Business Accelerator. The accelerator is accepting applications right now, but the deadline to apply is soon coming up. It is August 31st, so make sure you do so. We're going to watch this short video so you can see for yourself just how much the program is helping break down barriers to health equity in local communities. Watch.
The accelerator has been a great eye-opening experience. It's a chance to step back from yourself, step back from your organization, look at your goals and your missions in a different light, and to reflect on what you're really doing.
I never had a business background. I started a nonprofit because I was passionate about food justice, food insecurity. Honestly, I was frustrated because I was trying to find someone or that group of someone's who was responsible for this problem and who should be doing something about it. But then I realized that I'm someone who wasn't doing something about this.
This accelerator has been tremendous for us to come together with multiple entrepreneurs on the same issue, and I no longer feel alone.
The Business Accelerator through the American Heart Association has taught me all the skills necessary to develop a sustainable organization.
Thank you so much, American Heart Association. This opportunity has been wonderful. This money is going to go towards developing the SugarX watch and also developing a solution that better fits the lifestyles of diabetics.
Love to see just how many people are affected by that. Love it. All right, let's get back to the topic at hand and address a few more of your questions. This next one comes to us from Marcella in Akron, Ohio. She asks, if you could do one thing that would make a significant impact in addressing structural issues in healthcare and healthcare delivery, what would it be and why, Dr. Lewis?
Yes, I think that what I would recommend is mandatory sensitivity training and training on structural inequities and structural racism. The reason is because no one ever will look at themselves and say, I am a racist. You know, but if you work through a series of workshops with very focused curricula, you can actually then look and identify where there are biases, you know, and where there's that bias could actually influence how you see a particular person when they come in. I think that would have a major impact. The other, which would be more challenging, is to use digital health. You know, so if you use digital health, then you can track each person's individual experience real time, you can see exactly how long it's taking them to be seen if they're coming in with various medical conditions. And it would allow us to easily be able to understand whether or not patients are treated differently just based upon certain demographics.
Definitely. And I think that goes back to what we were talking about a little bit earlier. All right, Charles from Oakland wants to know the patient-physician relationship and the ability to build rapport. They are critically important. What can patients do to find physicians who are a good fit for them? That's a great question.
Great question. I often will say the most important relationship you have, in your healthcare is your the physician, and so that patient-physician relationship has to work. So if you don't trust your doctor, then once again, as I mentioned earlier, you're not going to listen to what he or she will say. You're not going to necessarily follow their guidance. You're not going to be forthcoming with information that can be helpful in terms of trying to allow that doctor or that provider to help you. So I think there are a couple of easy steps that you have to do. The first is to do your research, to actually see what their expertise is and to see whether or not they would work for you. Look at the location. So for instance, if it's going to be challenging for you to go and see the person because of your work schedule, depending on your healthcare needs and the specific care that you need to receive, you may not want to go too far away from where you live. And that's why it's so important that we have doctors where patients live. The other thing is to be prepared. I often will say, if you were having your taxes prepared, you wouldn't go into your accountant or the tax preparer's office with nothing and say, so am I getting a refund? You will come with the key things that you need, your W-2s, your expenses, your deductions, your donations, etc. And I think similarly, when you go in to see a doctor, you should be prepared. Here are the questions that I have. Here are the symptoms that I have, and write them down on a sheet of paper. Because otherwise, in a short time, you actually may not actually notice you may forget some of the things that are important. If it turns out that the doctor is not willing to go through your list of questions, then you probably need to find a new doctor. Because yes, we're busy, but you have that one interaction with your provider. And if they're not actually answering your questions in a timely way, and answering each of your questions, or basically saying, I can't answer all of them, but why don't you give me a list and I will answer them next week, or I'll see you in a few weeks and we'll complete this. So I think that's important. A quote that I always like is why should you care about what someone says if you don't feel that they care about you? And so if you don't feel that your doctor actually cares about your health, then you probably need to find a new provider.
Oof, great advice there. I completely agree too with writing things down. I always am jotting things in the note column of my cell phone so that I can pull it up when I see my doctor. So really good advice. Hope all of you are taking that into consideration. All right, our final question is from Monica in Dallas. She asks, why is it that a good education and higher paying jobs in some pockets of Hispanic and African American communities don't necessarily exempt them from the same poor health outcomes that those with less resources face?
Yes, I think part of it is culture, the culture of our society. So if we were to go back hundreds of years, and we don't even have to go back that far, when you look at certain parts of the population, I would say healthcare was akin, and this is controversial, but healthcare was akin to a veterinarian providing care for cattle. You want to make sure that they're healthy so that they can work. And this was kind of what happened historically, during the slave times. And unfortunately, over the years, healthcare was not preventive, but was reactive. So if you had an acute issue, you had it addressed, and then you would kind of say, I'm not going to see the doctor. And some of this was because of folklore, right? And things that you hear in the community. I've heard this back in Mississippi say, Leroy was healthy until he saw a doctor, then he died at 3 weeks later. And he hadn't seen a doctor in 25 years and was perfect. But there was a reason that after 25 years, he decided to go see the doctor. So I think even when, certain groups in our country actually are in upper middle class or even wealthier kind of situations, that mindset may stay the same, saying, I don't see doctors. I'm not going to do primary prevention. It's amazing when I look at people who come from more affluent backgrounds, they truly come prepared. They've already done their research. They know who I am. They know what my strengths are. And they've actually done some Google-based research on their healthcare. When we move, even if you look, there's one study that I like, which they looked at African Americans and Latinx people who actually moved from an impoverished zip code to kind of a middle class to upper middle class zip code. And if you look at healthcare, there's still healthcare disparities. It doesn't change. And so what that means to me is we need to do a better job of education about what's important, how we can actually achieve better health, and then really change and transition our mindset from reactive, saying, if I don't see the doctor, then nothing's wrong. And I see this a lot. And change to proactive, to actually say, I need to be proactive. The other issue, which I don't know, this is not based upon science, but just from personal experiences, when you have faith and you're focused on your health at the same time, there are people who will say, I'm just going to have faith that everything is going to be fine, so I'm not seeing a doctor because everything will be fine. And I often will say, well, faith without action is not going to work, as effectively. And so you have to kind of do things as well. And so I wonder if that is a contributing factor, that there's anxiety about the unknown, anxiety about I have hypertension, anxiety about conditions. And actually, I'm going to do something which I didn't anticipate, but I'll end it here. And that is, hypertension, as you mentioned, Chelsea, is prevalent in 50% of the African American community. And it's prevalent in about 75 to 80% of people in my family. And even though I eat low salt, I exercise, I keep my weight down, I don't drink alcohol, I don't do any of these things. Of course, I don't smoke. When I was about 6 years ago, I developed hypertension, and I checked my blood pressure at least once a month just to make sure, because I knew I was at risk, just because of my family history, because of who I am. And so when I did that, at first I didn't want to share it with people. I felt I was a failure. Here I am, a cardiologist with hypertension. And then it made me realize hypertension by itself is not a disease. What the problem is, if you don't treat hypertension, then it becomes kind of like those termites, that are at the base of a house. If you kind of nip it in the bud, there are no long-term consequences. That house can stand for a long time. But if you kind of ignore it and hope that because you don't talk about it, it doesn't exist, that's when you develop the long-term consequences and the house crumbles. That's when, for the body, you have the hypertension leads to stroke, to stroke, to heart attacks, to heart failure, to dialysis, to a variety of medical, to blindness, to a variety of medical conditions. So I would say, I'm saying this, if I can just touch one person, don't be afraid of what you may have, because ignoring it will just allow the matter to get bigger, and then it may get to reach a point where it becomes insurmountable. But if you're proactive, you may be able to nip it in the bud and actually have a long, healthy life.
Well, I hope people are listening to you and taking in everything you just said. Definitely appreciate you getting personal there. I know that that's probably not something that's easy to do. So appreciate that very much so. And you know what? I think it's so important when someone can associate with someone that even a cardiologist can have similar issues. So like I said, I really appreciate that. Now, we have a lot of questions that are still coming in, and unfortunately, we're not going to be able to cover them all in today's live show. But before we do move on, I wanted to address one more thing that I've been seeing a lot of our comments mentioning. There are those who still do not believe that racism and its effect on healthcare is real. So talk to us, Dr. Lewis, about the evidence and data. What information do we have that can help shift that mindset?
Yes, and so I think part of it is it's challenging because you can always try to use a multivariable model to try to explain away why there's a difference. I'll give you an example. We published a paper in the fall of last year in Circulation Heart Failure, where we actually looked at my former hospital, Brigham and Women's Hospital, where we felt that we were providing equitable care. And, in my experience, I noticed that my own patients who were African American and Hispanic were not admitted to the cardiology service. So we actually looked at this data over a 10-year period. Patients who went to the emergency department, we adjusted for everything. We did something called propensity scoring, which is as robust as you can do. And we basically found that just if you were self-described African American or Latinx, you are much more likely to be admitted to a general medicine service as opposed to a cardiology service. People may say, well, that doesn't explain anything. And I wouldn't call it racism. We called it structural inequity. By doing that, it softens the term a little bit. And it allows us to actually have the conversation. But I think we need to look at it. And when we published this, when we presented this at the American Heart Association, there were tons of people who came around and said, this is great. I know exactly what you're talking about. We see this in our hospital. We even saw this in other countries, where they're saying we see this as well, but it's not published. And the reason is because it's kind of embarrassing. No one wants to admit that there's a difference in how we treat patients. So that's just one evidence, but it's observational data. Like I said, the way to really answer the question would be to have actors portraying patients who actually go into the healthcare establishment with exactly the same symptoms, signs, etc., and see if they're treated differently. And if that's the case, then the question is, and if the only thing everything is constant except the color of their skin, then that would actually prove it. But it would be a hard study to do. But that's the best way of actually proving it.
Sure,
in terms of the impact, you can certainly look at. You can actually do just talk to patients and ask them specifically. Right now we have very few people of color who get enrolled in clinical trials, and some of it is because patients don't trust us. They don't trust us, and it goes back to the Tuskegee experiment. The fact that up until 1971, the NIH sponsored a study looking at the natural history of syphilis in Black men. Can we call that racism? It's hard to know. But what we know is it's at least an inequity, because the problem is when there's a cure for syphilis in the 1940s, you wouldn't go that long, over 30 years, without actually treating somebody, something that could be curative.
Absolutely. Thank you for answering all of these questions so thoughtfully. You have added so much value to this conversation. We're so lucky to have you with us here, Dr. Lewis. We're going to move on to our next segment. We're going to keep you here with us. It is, what would you say? All right, and what would you say? It's another opportunity to hear from you, everyone at home. If you've been with us throughout today's show, you already know what to do. Grab that phone and get ready to text your answer to 22333. So our first question is, have you or a loved one ever experienced overt racism from your healthcare provider? Yes or no? Those are our two options. You got personal with us earlier today, Dr. Lewis. So I'd be interested to hear if you felt like you've experienced racism from any of your medical care providers throughout your lifetime.
I would say in receiving healthcare, the answer is no for me. Part of that is probably because I'm a doctor. But in terms of being a doctor, the answer is yes. I've heard things, and that is, and it's not, I wouldn't call it racism per se. I would say it's a bias, and so the bias is that as a Black man, I'm not going to be a doctor, and so I remember going in to see a patient who's acutely ill as a cardiology consultant when I was a trainee, and the surgeons basically said, oh, we don't need transport, we're waiting for cardiology. And I basically just said, well, I'm here. And then of course they wanted to apologize, and I was fine with that, but I said, let's prioritize taking care of the patient. So I'll definitely experience that, but in terms of my healthcare, no.
Well, I am happy to hear that in terms of your healthcare, but it is unfortunate to hear that on the other end. I do want to say that a lot of the people who have answered say they are not experiencing overt racism from a healthcare provider. Are you shocked to hear that?
I'm not. I'm actually happy to hear that. Most times it's not overt. A lot of times especially for patients don't necessarily know what they know and what they don't know in terms of access. So for instance, if I look at heart transplant, and this is my opinion, anecdotally, but if I look at the number of heart failure cases in the states of Florida, Georgia, I know in the deep South, basically, you see a large number of people with heart failure who never even get approached for heart transplant. And the question is, why is that? Why is it that people in their 20s and 30s who would be candidates for transplant aren't even referred? We did a study where we looked at heart failure in Louisiana versus Boston to look at patient attitudes. And I was surprised that 0% of patients had a defibrillator, even though they all had ejection fractions less than 35%. Is this racism? Probably not. It's probably complex because it could be affordability. These devices are expensive, or it could be access to care. If you can't see a cardiologist, you can't get a defibrillator. If you can't see a cardiologist, you can't get a heart transplant. So I think awareness is incredibly important because those opportunities of omission become a problem. The last anecdote I would give you is there are times I was on the phone with 3 people yesterday who have medical problems, and they've seen their healthcare doctors and they're calling me. And there are a lot of things that the doctors didn't tell them. Is it because they're busy? Probably. Or is it because they're African American and they didn't even tell them? So if when they shared the data with me, I could say, okay, these are the things that I'm concerned about, and this is what I would recommend. That was just 3 people yesterday, 2 of who were family and 1 friend. And so I think this is something that makes it challenging to actually put this question into to highlight this question.
Absolutely. And we are seeing that more people are answering yes now. So almost 40% of people saying yes, they have experienced racism from a healthcare provider, which is very unfortunate. All right. I do want to say, clearly we were having some technical difficulties. It looks like my shot went down, but hey, we can see Dr. Lewis, and that's who we want to see anyway. So we're happy with that. We'll keep moving along with the show, though, until we can hopefully get this fixed, everyone. All right. The next question, we want to know how you feel walking away from today's show. Would you like us to continue this conversation around racism in future episodes? I'm hoping that the answer is yes, because look, until we keep having these conversations, things won't be changing, right?
That's correct.
All right, let's see what we're going to say. I'll give a shout out too, real quick, to some people who are watching us. We have Arian from California, Bern from Germany, and Babette from Louisville, Kentucky. So thank you for watching, you guys, from all over. So it looks like we have 50-50. I'd be interested to hear why some people don't want to hear about this conversation in the future. Are you surprised to see that we're pretty split on this right now?
I'm not surprised. I mean, I think, one thing I think it's really challenging. It's a topic that people don't really want to talk about. I would say, because of what happened and what's happening in the country, I think because of George Floyd and because of videos, basically, and frankly, kind of young people, there's been more conversation about racism and differences in treatment this year than in a lifetime, than in 50 years. And I think part of that is because with COVID-19, there wasn't a lot to do. So you didn't have distractions. But I think the other issue is by tackling this issue, it allows us to address racism in a very vulnerable part of our society. All the social injustices are wrong, but when it comes to healthcare, when someone is acutely ill and there's an opportunity to save a life, we want everyone to have a chance to have a long, healthy life. And that starts at birth. And that starts with trying to eliminate a lot of the problems that don't touch healthcare, but touch people. And that prevents people from actually achieving their best healthcare.
Absolutely. It looks like we have a lot more people saying, yes, they would like to see this conversation again in the future. So we are excited to see that. Dr. Lewis, thank you so much for guiding us through really what's a difficult topic for many people. But this has really been an eye-opening topic and a conversation that really can't be tackled in one show. So I hope that we can all agree that we need to continue this conversation. And I also hope that we can agree that access to healthcare is one of the most pressing issues of our time. And COVID-19 has exposed that in a new way for all of us to see. So, Dr. Lewis, I would love to open the floor for you for any final thoughts. So go ahead and take it away.
Thank you very much, Chelsea. I really appreciate it. And I like to thank all of you for tuning in. It's a topic that people don't necessarily want to talk about, but I think it is important. And I think just as we try to work to have everyone to live long, healthy, satisfying lives free of heart disease, I think it's also important to realize the role that racism plays in shortening life expectancy. So I think by working together, by treating each other the way we all want to be treated, we can actually help pull each other up so that we all have equal access and also equal opportunities for a long, healthy life. And I'd like to wish you health and safety as we continue through this pandemic.
I wish you the same, my friend. I hope that people have been taking in everything you've been saying. You've provided us with a lot of great personal experiences, some just incredible information and tips to take away. So we have appreciated having you, and I definitely look forward to furthering this conversation in the future. So thanks again for joining us.
Thank you.
All right, before we sign off, we have one more thing to share with you, and that is our weekly health hack. Health Hacks is brought to you by Stories of the Relentless, the American Heart Association's podcast. You can go to heart.org, iTunes, Spotify, or Google Play to find it. You're going to find many amazing stories and conversations on a variety of topics. So go check it out, subscribe, share your thoughts and the reviews, and share it with your friends and family. So this week's Health Hack, that is coming to us from Maggie. So hello, Miss Maggie. Thanks for sending it in. Maggie recommends using your crock pot to get a jump on dinner while juggling work and kids. Great idea, right? She suggests putting all the ingredients in a container in the fridge overnight so everything's thawed by morning. Then layer the tougher veggies like potatoes and cabbage at the bottom, and then put the more tender ones like maybe a zucchini or a peas on top. This, of course, is a good one, especially with everything that's going on right now, a lot of craziness in the world. So making dinner a little easier and healthier would be better for all of us. Remember, we feature a new tip every single week. So if you do have a great idea, send it to us at heart.org/housecalls. And maybe next week you'll see your idea live right here on the show. And don't forget, each week there are always a lot more questions than we have time to answer. So if we did not get to yours, remember, you can always maybe even see it on our House Calls After show. You can look for that on Wednesday on our social media channels and on the AHA's new podcast. And as I've mentioned a couple times, you can find some of our previous episodes at heart.org/housecalls. I'm so sorry, everyone, that the feed went down, but nonetheless, I think that you don't need to see me to appreciate what a great conversation that we have had throughout this show. So thank you so much for taking the time to watch with us today, and we hope you're going to join us again next Monday. Once again, I'm Chelsea Helms coming to you live from KNWA News Studio in Fayetteville, Arkansas. I hope you guys have a great week.
Learn more about House Calls, Real Docs, Real Talk, and submit your questions at heart.org/housecalls.